It is now my great honor to introduce our keynote address, Architects of the Future, presented by former Governor John Kitzhaber. Governor Kitzhaber is an emergency medicine physician who began his medical career in Roseburg and was later elected to the Oregon House of Representatives and Senate. During Governor Kitzhaber's tenure as Senate President, he authored the groundbreaking Oregon Health Plan, which sought to prioritize health services based on social values and clinical effectiveness. In 1995, Kitzhaber was elected as Oregon's governor and served in that role until 2003. He was elected again in 2011 and served until 2015. During Governor Kitzhaber's third term as governor, he was the chief architect of Oregon's coordinated care organizations, the first statewide effort in the country to meet the triple aim: better health, better quality, lower cost, with a focus on community and population health. During his career in medicine and public service, Governor Kitzhaber has transformed the healthcare landscape and increased access for all Oregonians. We are proud to count Governor Kitzhaber as a member of the OMA family.
Good morning, and thank you for inviting me to speak today. I can only say that I wish I could actually see you. I'm sitting here by myself in an office over at the OMA, and while I certainly understand the need for virtual conferences at this point in time, I do miss the audience. I miss looking at the people that I'm speaking to. I miss the human touch. So let's pledge to each other this morning that, notwithstanding the important role that telemedicine is going to play in our future, that we won't allow the human touch to be extinguished from the practice of medicine. I want to start today with a statement and see if you can figure out when it was written. Here's the statement. The fruits of the toil of millions are boldly stolen to build up colossal fortunes for a few, unprecedented in the history of mankind. Now, that could have been written in 2020, because today, three men, Jeff Bezos, Bill Gates, and Warren Buffett, have more wealth than the poorest 160 million Americans, or about half the population of the country. And today, income inequality is greater than it was in 1929, when 10% of the population possessed 84% of the wealth. Actually, the statement was written in 1882 as part of the platform of the newly founded Populist Party. And I'm not sharing it with you to make a political statement, but rather to illustrate two things. First, how little progress we've made in the past 138 years in terms of social justice and equal opportunity. And secondly, the fact that the relentlessly increasing cost of healthcare has become a major contributing factor to the inequities and disparities that exist today in our society. Over the past 6 months, we've seen the human consequences of our failure to embrace a policy of universal coverage. We've also witnessed the difficulty that non-medical essential workers have had obtaining adequate health protections, which has resulted in many cases in higher infection rates. These are people who don't have the luxury of working from home. They hold low-wage positions, often with little sick leave and little health insurance. They work in grocery stores and warehouses, farms and factories, restaurants, hotels, and retail establishments. And we've all seen Black Americans dying from COVID in dramatically disproportionate numbers, these deaths being attributable to structural inequities in our society that make Black people and Indigenous people and other communities of color more likely to have diabetes and heart disease and hypertension, and inadequate housing and fewer economic opportunities. Now, the pandemic did not create these inequities, but it certainly has exposed them. These are the very conditions of injustice that the Populist Party was calling out 138 years ago, and they've been with us since before the nation's founding, churning just below the surface and only indirectly visible when we examine the disparities in educational and health outcomes for chronically under-resourced and often racially or ethnically segregated communities. Now these disparities are laid bare, and the pent-up frustration is boiling over into the streets. Indeed, the protests of the past 3 months around Oregon, and particularly in Portland, are set against the backdrop of perhaps the most difficult set of challenges that our state's ever faced. Not only do we have a public health crisis, we have record high unemployment, and the legislation to extend unemployment supplemental benefits is stalled in Congress leaving tens of thousands of our fellow citizens with a shrinking capacity to be able to pay for food and shelter. The inability to reopen the schools this fall has added stress to children and to parents and to teachers, and we have a huge projected budget deficit. And all of these things are converging in the charged atmosphere of a very polarized and divisive election cycle. And now we have the fires. That's a lot. And I think we all recognize that we are at a dangerous and very uncertain point in the history of our nation and of our state. But I also think that our future will be largely determined by the attitude we take in how we approach these multiple challenges. You know, over the past few months, past few weeks when I've been overwhelmed, I've recalled a passage from A.A. Milne's Winnie the Pooh that I used to read to my son when he was very young. And in this passage, Pooh and Piglet are walking through a forest, and Piglet looks up apprehensively and says to Pooh, "Pooh, what if one of those trees falls on us?" Pooh looks at him and says, "Well, what if it doesn't," right? So the point is, how are we going to respond to this? And I think there's two choices. We can respond by clinging to the past and by defining ourselves as champions of a status quo that is increasingly unsustainable fiscally and indefensible morally, or we can choose to be the proud, courageous architects of a new future. And knowing you as I do, I'm pretty sure what the answer is going to be. 10 years ago, we faced a similar set of circumstances, and we rose to meet the challenge. In 2011, Oregon was in the depths of the Great Recession with high unemployment and a polarized electorate, and a divided legislature that was facing a $3 billion revenue shortfall, $1.2 billion of which was in the Medicaid budget. Now, one path was to cling to the status quo and drop tens of thousands of Oregonians from coverage or cut provider reimbursement rates by up to 40%. The other path was to redesign the delivery model to get more value for each dollar we were spending. And we came together as an industry and as a state, and we chose that second path. And the result, of course, was our coordinated care organizations. While not perfect, they did help save the state hundreds of millions of dollars during the Great Recession and expand coverage and successfully navigate the politics of managing a large budget deficit without tearing ourselves apart as a state or as a community, which is very, very important. Now, a decade later, we find ourselves in a similar set of circumstances, and again, we need a strategic plan. What's different about today than 2011 is that healthcare has become the largest all funds expenditure in the state budget and the second largest general fund expenditure, which means that the state budget, which is facing a $4 billion revenue shortfall, can't be brought into balance without significantly reducing the cost of healthcare. And without a well-defined strategy, the healthcare budget could become just another moving part in a balancing exercise, budget balancing exercise that's disconnected from any long-term responsible policy framework. And the 2021 session could disintegrate into a political fight in an election year between stakeholders all trying to get their share of a shrinking pie. We have the opportunity to avoid that outcome, which wouldn't be good for you or for the healthcare system, or most importantly, for the citizens of the state of Oregon. We have the opportunity to lead by developing that strategic plan and building on the steps we took in 2011 to accelerate the transition to goals that we already recognize are necessary, and in particular, the move to value-based payment. In short, I believe we have a once-in-a-generation opportunity to better align our system with caring and with compassion and with the goal of improving health of our state and the people who live here. No one is more qualified to lead that effort than people who have dedicated their lives to the healthcare profession. If I could have the next slide, please. Over the next few years, and particularly over the next 10 months, if I could have the next slide, please. Over the next few years, and particularly over the next 10 months, we're going to face three interrelated challenges: to reduce the total cost of care without sacrificing access or value, to maintain the integrity of the delivery system in a resource-constrained environment, and to effectively address the health disparities that continue to exist in our society and in our healthcare system. So over the next few minutes, what I'd like to do is talk to you and walk you through how COVID-19 has fundamentally changed the political and fiscal landscape in which the healthcare system operates. And that discussion hopefully will help inform the key elements that we need in our strategic plan to meet this challenge. So among the many impacts that COVID-19 has had on Oregon, three in particular stand out. I have the next slide, please. The first impact is the impact that the COVID-19 pandemic and the steps for social distancing have had on utilization of healthcare services, which, as you know, over the past 6 months have dropped by as much as 40% from historic patterns, creating a fiscal crisis, particularly for those portions of the system that are most heavily dependent on fee-for-service. That has exposed in a very real way the irrationality and I think the vulnerability of a payment system that is focused more on volume than on value. And that fact should also help inform our strategic plan. I can have the next slide, please. Perhaps more importantly, however, is the impact that the pandemic has had by exposing the extent to which our healthcare system and its fiscal viability depend on public resources and on public debt. And that's kind of an abstract concept, but it's very, very important. So let's look at it a little closer. Consider the fact that healthcare is the only economic sector that produces goods and services that none of its customers can afford, right? So the only way this works economically is because the cost of medical care for individuals is heavily subsidized with public resources, either directly through public programs like Medicare and Medicaid or CHIP, or indirectly through the tax exclusion for employer-sponsored coverage or the subsidies you get if you buy a policy through the ACA exchange. Next slide, please. So if you look at this subsidy map, you can see that over 90% of Americans currently get some form of public subsidy to help pay for the cost of their health care. The subsidy for Medicaid is federal and state. If you get a policy through the ACA market, your subsidy comes from the federal government. If you have workplace-based coverage, the subsidy comes from your employer and from the federal government. And of course, Medicare is primarily a federally subsidized program. The point is that this system only works because it's heavily propped up with public resources. We can also see from this subsidy map that the only people who are not entitled to a subsidy are the 32 million uninsured Americans. If you think about it, these people are all working because they're making too much to be eligible for Medicaid, but can't afford the cost of a private policy. So while not entitled to a public subsidy themselves, through their taxes, they're underwriting the subsidies for everyone else. And this is clearly one of the most egregious inequities in the healthcare debate, and it drives much of the debate from a political standpoint. But not only is the economic viability of our system dependent on public resources, it's increasingly dependent on public debt. And that's because Congress is borrowing ever more money to pay for current programs and services, including healthcare. That's reflected in the growing national debt. Now, the national debt represents the amount of money that's borrowed to cover the difference between what Congress is spending and the taxes available to pay for it. Since healthcare today accounts for 28% of the federal budget not spent on interest and is expected to grow to 33% by 2028, healthcare has become a major driver of the national debt. Next slide, please. That means that as the cost of healthcare continues to increase and as the population ages, the economic viability of our healthcare system will increasingly depend on borrowing money and on the capacity of the federal government to absorb more debt. If the capacity to borrow is somehow constrained, then the financial underpinnings of the whole system begin to unravel. And as we'll discuss in a moment, COVID-19 has created exactly that kind of constraint on borrowing, thus bringing a healthcare financing crisis, which was on our horizon, right to our doorstep. Next slide. Finally, since the cost of healthcare is claiming an ever-growing share of public budgets, it's undermining our ability to invest in other things that we know have a far greater impact on the health of the population. That means that as the cost of healthcare continues to increase, we're going to be reducing the amount of money that we can invest in the social determinants of health. And that's things like, of course, healthy pregnancies, nutrition, housing, stable families, safe communities, education, and economic opportunity. And as COVID-19 has graphically, and I would say tragically demonstrated, the burden of our failure to make these social investments has fallen disproportionately on the poor, and particularly on Black people and Indigenous people and communities of color. So now let's take a moment with that scan of the landscape and look at the federal response to this situation and then try to bring it back here to Oregon. Next slide, please. The crucible that we find ourselves in today is the result of the intersection between public financing and public debt and the economic downturn caused by the pandemic. In order to prevent a complete collapse of the economy, there's been this massive federal intervention, both from Congress and the Federal Reserve, to keep credit flowing and to provide loan guarantees and direct payments to businesses and to individuals. There's another relief package in the works, but it appears to be hopelessly stalled in the United States Congress. In any event, this massive federal intervention, even to date, is going to leave us with an unprecedented budget deficit and a national debt that's approaching $28 trillion, which is going to leave very little capacity to absorb what is a projected 60% increase in the size of the healthcare economy by 2028, from 3.7 trillion to 6.2 trillion, especially since prices are projected to account for about 43% of that spending growth. So we need to come to terms with the fact that we're entering an era of profoundly constrained public resources, and it will be particularly difficult, perhaps impossible, to afford the projected rate of medical inflation here in Oregon and across the nation, particularly given the economic losses that employers and individuals have experienced, and of course the massive public debt that's been accumulated just to keep the current system from falling apart. Here in Oregon, if I could have the next slide, please. The legislature, as I mentioned, is facing a $48 billion budget deficit for the 21-23 biennium that begins next July, just 10 months from now. While the state does have about $2 billion in reserves, these are going to have to go to address problems across the entire general fund, not just in healthcare. And it is unclear if or when additional federal funding is going to become available. In any event, a federal bailout is not something we can count on, and I would suggest that waiting for outside help is not a strategy, it's a recipe for disaster. That's why a strategic plan is so critical. So we need to start with a clear idea of where we want our healthcare system to be in 5 years, so that we can ensure that the individual steps taken by the legislature next year are not simply focused on eliminating a revenue shortfall for a 2-year period, but actually put our healthcare system on a sustainable footing for the 2023-25 biennium and beyond. Now, certainly there's a lot of risk in the months and years ahead, no question about it, but I would argue that there's a far greater risk in clinging to the belief that we can return to the old paradigm a few months from now. Because even when the economy recovers, it's not going to begin to mitigate either the national debt or the deep fiscal losses suffered by the state of Oregon. So the fundamental reality is that we are going to have fewer resources, not more resources in the months and years ahead than we had in the past. I think the central question for you to begin to consider is how would we manage to a total cost of care level that's maybe 15 to 20% lower than what we had in 2019. Have the next slide, please. So I'd like to use the remainder of my time to offer one way that we can approach this, that we can manage to that lower total cost of care level. And let me preface this by saying that the devil is always in the details. So what I'm going to present to you is just one way and a broad outline of how we could address 3 key objectives: to maintain the integrity of the delivery system, to expand coverage, certainly not reduce coverage, and to reduce the total cost of care. I think those are the 3 key objectives. Now, as I said, there's other ways to approach this, but I think you need to keep in mind that the general fund expenditures for healthcare will be severely constrained in the next biennium. And the decisions on what that looks like are going to be made by legislators starting a few months from now. So I believe it's in your best interest, and I believe it's in the best interest of the state of Oregon, for you to provide leadership and offer a strategic plan, one that can be embraced by the rest of the healthcare sector, to guide the inevitable changes that lie ahead. So the outline that I present here is going to be focused primarily on those populations where public dollars are at risk, because as we discussed earlier, healthcare competes directly with these other important social inputs. These populations include Medicaid and the healthcare programs that provide coverage to public employees, the Public Employees Benefit Board, or PEB, and the Oregon Educators Benefit Board, or OEB. Now, I've also included the ACA individual market in this, and let me explain why. As you know, the ACA subsidized market was created by the Affordable Care Act to help low-income Americans without employer-sponsored coverage. And indeed, this is probably the only option for Oregonians who earn more than 138% of the federal poverty level, so they're not eligible for Medicaid, but lack employer-sponsored coverage and find it difficult to find coverage in the individual market. So although this subsidized market is paid for, the subsidies in the market are paid for by the federal government, not the state government, so it doesn't impact our $4 billion budget deficit. Keeping that market affordable is a key element of moving Oregon towards universal coverage, which is a point I'll come back to in a moment. Next slide, please. So in making the case for this approach, I would make 3 points. First, as we discussed earlier, healthcare has become the single largest all funds expenditure in the general fund and the second largest general fund expenditure, second only to education. And this growing liability on the state general fund is competing directly with resources that are needed for housing and other social services that also contribute to health, not to mention propping up our educational system. Secondly, healthcare has also become a growing part of the total compensation package for public employees, which means that in the collective bargaining process, wages are pitted directly against healthcare benefits. Also, for public employees, the general funds that go to support their healthcare compete also with wages and with other investments like increasing nursing staff ratios and decreasing class size, and of course, investing in the social determinants of health. Traditionally, in collective bargaining, the goal of the bargaining unit is to reduce to the greatest extent possible the out-of-pocket costs to their the union members. The problem with focusing only on that aspect of the total compensation package without challenging the cost structure or the quality or the efficiency of the care that's being delivered simply drives down wage growth and puts additional pressure on the general fund. And finally, I want to mention that as we discussed earlier, the fee-for-service payment system in a real sense failed the healthcare system during this pandemic and exposed the vulnerability of a business model that's based on volume rather on value. And although for years we paid lip service to this notion of moving from volume to value, the pace has been glacially slow. Now's the opportunity to speed it up. I think that the current projected revenue shortfall creates an urgency, if not a necessity, in accelerating that movement from fee-for-service to capitated models, probably incorporated in global budgets indexed to a sustainable growth rate, and risk-based contracts with provider networks. Over the past 5 years, we've demonstrated the viability of that through our CCO model, over which 25% of Oregonians are now in that model, and it contains exactly those elements that we need to move into the commercial market. So could I have the next slide, please? There are 2 central elements to this proposal I'm laying out today. One of them is to ensure maximum enrollment in existing programs, and the second is, of course, to reduce the total cost of care. Next slide, please. We know that if only 80% of those who lack health insurance coverage in Oregon made use of coverage for which they are currently eligible, that is the Oregon Health Plan or the ACA individual market, the number of Oregonians who are uninsured would drop from around 280,000 to 34,000. That's a drop in the uninsurance rate from 6.2% down to about 0.08%. The top 2 reasons people give for not being covered is they're concerned about high out-of-pocket expenses or not knowing that they're eligible. Well, we know that there are no premiums and no deductibles for the health plan, and those with incomes between 138% and 250% of the federal poverty level are eligible not only for premium subsidies, but also for cost-sharing reduction subsidies in the ACA market. The problem is that given the relentless increase in the total cost of care, even the ACA market is becoming unaffordable for a growing number of people. So the general fund would certainly be strained if everybody who is currently eligible for Medicaid were to suddenly enroll. In other words, even if we can ensure that everyone is enrolled in programs for which they are currently eligible, the steady increase in the total cost of care will undermine our ability to maintain that coverage over time, not just in Medicaid, but in the commercial market as well. So that means our top priority must be to address the total cost of care and to ensure that we're getting value for the public subsidies that are supporting the healthcare system. That involves taking steps that impact both Medicaid and the commercial market. So let's walk through those. Next slide, please. First, I think we need to consider capitating hospitals for the Oregon Health Plan. Bay Area Hospital in Coos Bay and St. Charles in Bend are already capitated. Pennsylvania is moving in this direction for its rural hospitals. And as we discussed earlier, the economic fallout from COVID-19 has demonstrated the perils of clinging to a pure fee-for-service system. Second, I think we should reduce to some extent the 3.4% per year growth rate. Even a small reduction in the trend yields significant savings long term. Third, we need to remove the excess administrative burden that has been added to the CCOs as a part of CCO 2.0. I would cite as an example the new risk-based capital requirements for CCOs. Next slide. We also need to seek additional Section 1115 waivers for two purposes. One, oops, I seem to have lost my place here. Yes, here we are. The waivers would be for two purposes. One, I think it's really important that we move CCOs back to a true global budget, which was, of course, the original intent. It's important to move away from a claims-based medical loss ratio to a health loss ratio, where CCOs are not penalized in the rate-setting process for investing in the social determinants of health, for which there may be no claims or no billing codes. We also need to try to get additional federal resources into the state during this next waiver period, which we did back in 2011, if you recall. And I would suggest trying to get additional federal resources for CCOs that will spend up to 3% of their budget on community-based social determinants of health, which will try to directly address health equity issues. And secondly, enhance payment to providers who can demonstrate that they can address the culturally and linguistically appropriate services needed in their communities, particularly around behavioral health. Next slide, please. We also need to establish much clearer access and outcome requirements for both mental health and social and substance use disorder. As you know, the pandemic has created this huge growing need for effective behavioral health services. Let me give you just a couple of statistics. Today, 1/3 of Americans are reporting stress and anxiety levels that are difficult to cope with. And that, of course, goes hand in hand with the difficult economic circumstances that they're facing. 59% of primary school teachers and 49% of secondary school teachers are experiencing high stress and anxiety. Furthermore, we know there's an increase in substance use disorder, which is probably the biggest cost driver for coordinated care organizations. So significant investments in this area can also yield cost savings downstream. Finally, I think we need to better coordinate the state purchasing power, particularly to negotiate prices for high-cost specialty drugs for which there are no generics. State financed populations that could participate in this purchasing pool could be Medicaid, PEB and OEB, the Department of Corrections, and the State Accident Insurance Fund. And I also think we should make better use of the Northwest Prescription Drug Consortium. Now, in addition to these steps that we are taking in the Medicaid program, we also have to take actions in the commercial market, which gets us right to the heart of the matter. Extending the CCO model into the commercial market was always part of the original vision of our transformation 10 years ago, but we just haven't gotten it done. And that's because it's a heavy lift. It gets right to what keeps us ticking. It gets to reimbursement levels, it gets to payment levels. It is a heavy lift, but now is the time that we need to do it. Next slide, please. To me, this involves moving both the ACA individual market and PEB and OEB into some away from fee-for-service and into a risk-sharing arrangement, probably within a global budget, that's based on a uniform fee schedule that could be negotiated, moderately well-managed utilization assumptions, and a value-based benefit design. Next slide. Now, for this to work, we've got to have a new equitable risk-sharing arrangement between payers and providers to ensure that they share equitably in both upside and downside risk. If we're going to have to reduce the healthcare spend in this state by 15%, there's not enough margin to go around if we all cling to our own silos. So we've got to realign incentives between payers and providers, with payers assuming primary responsibility for true insurance risk, that would be extraordinarily high-cost patients or out-of-area care, with providers assuming primary responsibility for managing utilization. We also need to make sure that risk is not simply held at the plan level and cost managed by denials or prior authorization, but that the risk actually flows downstream to the providers with appropriate alignment of incentives to manage both quality and cost. Now, what I've laid out to you is only one way that we can approach this difficult challenge, but it does incorporate the three objectives that I think are essential. reducing the total cost of care without compromising access or value, maintaining the integrity of the delivery system in a resource-constrained environment, and effectively addressing health disparities. These are the goals. These are the waypoints that will help us navigate the difficult waters ahead. Now, some of you may disagree with some or all of what I put on the table here today. Fine. If so, you need to come up with something else, because if we are unwilling to let go of the shore, the surf will pound us to pieces. I believe that the only way to approach this challenge is to embrace the change, not to resist it, and in fact, to lead that change. So my message to you today is simply this. I believe that you must assume a leadership role to develop a strategic plan to present to the Oregon Legislative Assembly, and be willing to sit down with other key stakeholders, including hospitals and other providers and consumers and payers, in a common effort to get to yes and help guide this state and its healthcare system through the most difficult economic and social moment in its history. Last slide, please. Somewhere in America, during this difficult time, a state needs to demonstrate that we can weather this storm without losing our sense of community, without losing our commitment to one another, and emerge stronger and more unified than when we began. Let's make that state Oregon, and let's make this proud organization the chief architect of a brighter and better, fair, and more sustainable future. Thank you.
Thank you, Governor Kitzhaber, for your perspective and your clear plans in an approach to tackle some of these problems. I really love how you say we won't allow the human touch to be taken away, especially during the pandemic when social isolation has become such a real thing. So thank you very much for your comments. We do have several questions coming in, and we have a few minutes to answer those. So I'm just going to jump right in with our first one.
You're good.
Oregon currently spending 20% of healthcare dollars on administration, not healthcare. This is double the administrative costs of other industrialized nations. How can Oregon spend less on administration and more on healthcare?
Well, I think, basically changing the payment model from fee-for-service to a global budget, a capitation, where providers are operating within the context of a fixed amount of money, and where providers are managing that utilization, removes a lot of the necessity for, actually, I would say, the entire billing system. And if you think about it, we've got this huge industry of diagnoses and treatments, and the amount we spend on billing and collection is just enormous. So I think that if, in fact, you move to capitation and some kind of global budget, I think you could put a limit on the administrative cost. I'm sure we can drive that down, but the real cost savings are not going to be in administration. They're going to be in providing better care, the right care at the right time at a lower cost. And we've demonstrated with the CCOs over the first 5-year waiver period, we saved about $1.1 billion in total funds. And so I think we know where we need to go. The question is, how do we make that transition?
Thank you. Another question about cost. The biggest increase in Medicaid costs are related to pharmacy costs. How do you propose lowering the 3.4% target if drug costs increase at a much higher rate?
Well, again, as I mentioned, I do think that we're making a mistake not to pool our purchasing power. If you add up the covered lives we have in Medicaid and PEB and OEB and other state programs, there's a lot of juice there to negotiate, particularly high-cost specialty drugs for which there is not a generic. I would also think that having some conversations about aligning Medicaid purchasing with Washington and California would be also productive. And, should Senator Wyden become the chair of the Senate Finance Committee after the election, we should go after that prohibition that was put into Medicare Part D that prevents the federal government from using the volume of Medicare to negotiate drug prices. So I think there's a state and regional approach. There's also a federal component to this.
Great. So shifting gears a little bit to a question that's more near and dear to my heart as someone who practices narrative medicine and teaches the importance of stories. we have a question, as we move, as you mentioned, towards quality of care and not quantity, especially using Black maternal mortality rates as just one profound example, it seems to me that one key element of the solution must be time to listen to patients so that their concerns, symptoms, and needs are actually heard by clinicians. How can we support each other to make time and slow down as clinicians to take better care of our patients? And are there any good examples of which you are aware in the setting of all of this cost containment and timing issues that we have as physicians and physician assistants and nurse practitioners here in Oregon?
Well, I think this is a question that goes far beyond healthcare. I mean, I believe that if we really want to get at the root causes of institutional racism and deal with the disparities in our society, most of them have their roots before people actually get into the healthcare system. And it's this profound lack of investment in families and children and communities and neighborhoods, which leads, I think, to the huge disparities that come downstream. And, I think this is going to require the seeding of resources and power, probably from healthcare and education, which are the two biggest components of our general fund, and into social services. And a key part of that is making sure that the people who are impacted by those services, be that healthcare or education or early learning, have a central and meaningful role in designing the way those systems are put together. In many cases, I think we come in and say, well, here's how we see the problem, and we're gonna address it this way. We need to listen and engage and cede power and influence to those individuals in order to ensure that they have some ownership in how those services are delivered, because they actually know best. We don't do that very well as a society, not just in healthcare, but I think across the board. And I think that needs to be a sort of an integral part of this transition in healthcare and in redesigning the educational system and other services across the board here in our state and in our country.
Thank you. Another question came in. Thank you for your inspiring remarks. As physicians and PAs have engaged and provided leadership in reform over the years, supporting policy that helps all citizens, payers have systematically taken advantage to decrease reimbursement while increasing their profits, and leading to reduced access to many essential services and loss of trust. How do we engage payers in these goals in a way that does not significantly disadvantage providers?
Well, I do think I mentioned this in my remarks. We have to develop a fundamentally different risk relationship between payers and providers. We have to realign the incentives between payer and providers. So we're going to continue to do exactly what the person who asked that question suggested. And we've been having some very productive conversations with some of the major payers in Oregon: Pacific Source, MODA, Providence, Kaiser Permanente. Just taking those, you have probably 80 or 85% of the market right there. And I think there's a willingness to sit down, particularly with this recognition of the constraints that are coming on the healthcare system, to renegotiate, to redefine that risk relationship. And, you can do those things in Oregon. We all know who the CEOs of those organizations are. This isn't California or New Jersey. And so I do think as a central part of this, we need to convene those stakeholders, the payers, the hospitals, the physicians, and have that conversation. And I'm very optimistic that if we approach this with the idea of creating a sustainable healthcare system for all the parties, but most importantly for the individuals who are receiving those services, I think we can get there.
So another question then, how do you think a capitation model would work for patients with palliative concerns, specifically those who are not necessarily ready for hospice, but are not expected to recover from their diagnoses and may live for many years? So how does patient autonomy fit into this when they choose not to follow the plan of care? Kind of going back to your comments about really having the patient be a part of that decision-making team.
Well, I think that I'm not sure it's so much a capitation issue as it is an acknowledgement of the importance of that aspect. My mother, who died a number of years ago, was living at home, and we were able to actually provide her what she needed, which wasn't medical care. It was the activities of daily living, cleaning the house, taking her to the bathroom, right? And at the time, she didn't need hospice care, right? She needed basically emotional and domestic support. And that wasn't paid for at the time. And if we were to actually reimburse a PA or a nurse or a physician to actually have this conversation with people, not when they're on their death's door, but when they're coming in the front end of the healthcare system about what, how do you want your end of life to look like? Who do you want to be there? What's important to you? Where do you want to be? And have that conversation early, because this is not a medical issue. This is when you've passed the point. There's a difference between cure and care. And what you're talking about is the point where it's about care and compassion and emotional support. And that needs to be acknowledged as a part of the system and legitimized. And we need to anticipate that as a payment aspect of the capitation rate. And the fact is, almost no one wants to die in an acute care hospital, but the system drives them in that direction. So we're not talking about telling someone they can't go to the hospital. We're giving them a choice for an end-of-life venue that makes sense to them, which, by the way, saves a whole boatload of money in the long term.
Yeah, I think that's a great segue into another question, which really goes back to a question that we asked Director Allen about public health, and that public health funding often is really able to fill the gaps of clinical care. What do you think the role of public health and tribal health is in these efforts at a community level? And how can we as physicians and physician assistants and other providers really capitalize on the relationships with our public health colleagues?
Well, I think public health is actually the cornerstone of health, right? I mean, what I did in the emergency room is I was treating after the fact. I mean, people showed up there because in many cases they showed up because of unmet social problems. We take care of their medical problems and then send them back to exactly the same environment. So I think you have two issues here. You have the traditional public health issue, which is really, I think the pandemic in a way was a blessing in the sense that it showed us that we have such a fragile, in some cases non-existent, public health infrastructure, or at least there's a lot of gaps in it. And that's one lesson we need to learn. It's about resources, but I think it's also about engaging the public health in the same conversation we talked about earlier. That is the populations that we're trying to support from a public health standpoint need to be really engaged in what that looks like. So public health, there's a huge opportunity here to really integrate public health as a foundational piece of our medical care system, of our healthcare system, because that's what creates the trajectory, the positive trajectory, along with those social investments we discussed, that reduces the input into the medical care system, right? So it reduces costs long term, but it restores the caring. It restores the caring to the healthcare system. So we have a huge opportunity here. I mean, the system's been blown up. The pieces are up in the air. We can knit them together in another way. But as I said earlier, we need a strategic plan to do that. And I think you folks are in a position to lay that out and bring it to the legislature next year.
Great. And I think we have time for maybe one or two more questions. One thing that's coming through in some of the questions here is just the concern about provider burnout. In the previous talk, we looked at the triple aim, and I'm just curious about your thoughts on the quadruple aim, really adding in that healthcare professional well-being and sense of meaning. And the question that's come in is really, what do you see the change from fee for service into these different models of healthcare? How do you see that impacting just the providers' general mental health and well-being and sense of fulfillment in their careers?
Well, I mean, I do think we need to have good, adequate reimbursement. We need to create obviously incentives. That means upside risk for managing patients well. But I think if you are on a capitated system where you have your resources on the table, you know what they are, it reduces the need for the doorknob visit, right? I mean, you just have to see people as a mill in order to pay the bills. So I think that's very important, and that's why it's important to have that conversation about what the assumed fee schedule is going to be when you're developing the capitation rate. What's going to be included in that, right? And when you actually seed risk downstream to providers, you need to create the align the incentives so that if you are really efficient in managing your patient population and they don't come to visit you on a regular basis because they're well, you need some benefit from that. I do want to add, though, I also think that we need to fundamentally change, and this is not a state issue, it's a federal issue, the subsidies for medical education. And I do think the subsidies need to be significantly increased for those specialties that we know we're going to need if we're moving to a population health system. That is primary care. To create a system where you're forced to go into a higher paying specialty because you're worried about student debt is not aligned with what we're trying to do here. So medical education has a key component, I think, as part of the solution.
Thank you. I really appreciate you addressing that as someone who works closely with medical students and really see that kind of tremendous burden on them going into different healthcare specialties and fields. So that's all the questions that we have time for today, but I did want to give you an opportunity to make any last additional comments before we have to say goodbye.
Well, I'm sitting in the seat of my car here.
I see.
My lovely studio. To me, it's just bizarre I guess it's a great technology, but I sure miss interacting with people, and hopefully we'll get to do that soon. This organization is really remarkable. When we did the Oregon Health Plan back in 1989, it was the OMA that basically drove that forward. And we were accused of rationing. We were being beaten up by everyone around the nation. And it was this organization that stepped up and said, no, there's a better way to do it, and we want to be in the forefront. You were there when we created the coordinated care organizations. And I would say this moment in time is even more crucial, and we can change the vector even more significantly over the next year. And I think this is designed for you. This is our time. This is your time. So I hope you really take this seriously. I know you will. And I'll do anything I can to help support you. I'm very excited about the great contribution you'll be making here over the next year or two. Healthcare and health in Oregon.
Great. Thank you very much for taking time to be with us today. And enjoy the rest of your weekend.
Thanks very much.